Garza, and today I will be presenting my senior honors thesis presentation, Beyond the Addiction of Opioids, an analysis of the opioid crisis in the United States. So to set the premise of my research, I focused on the following questions. To what extent did the United States influence and enable the severity of the opioid crisis? How and what tactics did other countries take that the U.S. can implement and learn from to avoid experiencing the opioid crisis? And what drug policies and practices constituted the skyrocket in addiction and drug-related deaths in the United States? So a brief introduction as to what are opioids. They are known to be one of the most effective yet highly addictive drugs used to treat and manage pain, and most importantly, they can only be legally obtained through a prescription from a doctor or a physician. Some of you are probably familiar with some of these terms, which are examples of opioids here. We see morphine, hydrocodone, oxycodone, heroin, fentanyl. These are a few of the prescription pain relievers, but also some illicit opioids. Methadone and buprenorphine, which I'll introduce and talk about a little bit later, are medications used to combat opioid use disorder. And to gain a grasp and understanding of the potencies and how dangerous opioids can be, morphine is the least potent opioid, and it is used to treat and manage like the lowest levels of pain tolerance. And then we have it followed by hydrocodone, oxycodone, methadone, all the way to fentanyl, which is the most potent. What is the opioid crisis? The opioid crisis is otherwise known as the opioid epidemic and can best be described as the public health and economic crisis that erupted in the United States and has continued to endure through a series of waves. Historically, it's been known to emerge through 3 waves. However, we saw an emerging 4th wave in 2019 with the influenza of COVID. In the first wave, which began in 1998, shortly after the release of OxyContin in 1996, we saw a rise in prescription opioid overdose deaths, followed by the second wave, which started in 2010, which was marked by the rise of heroin overdose deaths. And then the third wave in 2019, which was the rise in strong synthetic opioid overdose deaths with drugs such as fentanyl. And then the fourth wave in 2019, we saw a combination of psychostimulant drugs with some of the strong synthetic drugs. So we saw psychedelics and other drugs being laced with fentanyl. An introduction as to what the opioid crisis is. We see a graph here that really contrasts the United States and their drug and overdose deaths, marking it significantly higher than any other country. Although it's followed closely by the UK, it's still an immense amount more than any other country. And the United States has ranked number 1 with over 500,000 deaths per capita through the years 1996 through 2019. The differences in the opioid epidemic and addiction between the U.S. and other countries correlates to drug policy, healthcare systems, government strategies, and pharmaceutical company influence. So to begin with drug policy and legislation, the United States criminalizes drug use more than any other country, and it incarcerates people at a much higher rate, causing a disproportionate impact on people of color and minorities and their communities, which creates this stigma and hesitance for these people who are addicted to seek treatment and causing unsubstantial rates of the United States uses the Food and Drug Administration, the FDA, for a means of regulation and control. And at the early onset of the opioid crisis, the FDA was limited in its oversight of marketing and promotion of controlled drugs. And it's worth noting that the United States, just other than the country of New Zealand, is the only other country to promote drugs publicly through advertising, marketing it through like commercials, billboards, ads. So with this regulatory model that the United States uses, a slower and less direct ability to govern the use of opioids is a major downfall, and it's in comparison to other countries like Germany. So consequently, this provides the autonomy of prescribing to medical providers, creating a lot of challenges that pose difficulties to monitor safe prescribing, enforcing laws, and identifying bad actors in the healthcare system, which are those such as medical providers who may capitalize on the opioid crisis to promote personal gain and wealth. So a limitation of the United States' success in reducing the crisis is directly correlated with the lack of regulation of the daily dose of opioids a person can receive, the place of long-term cap use, and a restriction of who can receive opioids. So initially, before OxyContin was released, opioids were only allowed to be distributed to those with cancer-related pain, and after the release of OxyContin, we saw opioids being endorsed and prescribed to people with non-cancer-related pain. So with the United States drug policy leaning more towards law enforcement rather than treatment, we see a disproportionate impact on people and their addiction. So looking at other countries, we see how they implemented policies that focus on helping rather than punishing people struggling. For example, Germany spotlights and stresses the importance of harm reduction and public health when addressing opioid abuse and addiction. They tackled the issue from a medical point of view, using two regulatory systems to avoid reaching a crisis at the same capacity as the United States. They established the Narcotics Drugs Prescription Ordinance and the German Narcotics Drug Act. And these two acts monitor and permit the use of prescription distribution of opioids for strictly cancer patients only. And again, more stringent policies are in place for other countries when prescribing opioids, such as specific dose limits being set, and only allowing prescriptions to be distributed with less than a 3-week supply. Now, looking at pharmaceutical distribution and Purdue Pharma, not only does the United States rank #1 for overdose mortality rates, but also #1 for the highest distribution rates for opioid prescriptions. This is because Purdue Pharma, which is a pharmaceutical entity owned by the Sacco family, holding an outstanding accountability for the pharmaceutical distribution. They patented and released the drug OxyContin in 1996 and began to endorse it as a treatment option for non-cancer-related pain long before it was even approved by the FDA. So by 2004, OxyContin had become the most abused prescription drug in the United States. And by 2002, we saw a 10-fold increase in OxyContin prescriptions for non-cancer enduring pain from 670,000 to about 6.2 million. And then we saw a 4-fold increase in prescriptions for patients with cancer-related pain. Among other things that Purdue Pharma did, they basically created a scheme by financially supporting universities, research, clinics, medical providers, extorting their wealth as power and going beyond legal and regulatory laws for prescription distribution to endorse OxyContin and other opioids. They, like I said, funded organizations to promote opioids as the optimal pain management solution from all levels of pain, going from corporate medical centers to nonprofit organizations. They lied to the DEA and FDA about the journey and prevention steps taken to prevent such a wide dispersion of OxyContin, when in reality, they knew and increased the production amount to sell and distribute. Another interesting fact is that the officer of the FDA who authorized the release of OxyContin in a 106 milligram tablet, shortly after releasing that, went to go work for Purdue Pharma as the head of their marketing and sales team, after he admitted that that was an amount that could kill a child. And lastly, Purdue Pharma adopted a policy model for the Federation of State Medical Boards, which has been adopted by a majority of states in the United States, permitting the practice of physicians to prescribe these opioids and OxyContin without being held liable for addiction. Now, looking at treatment and harm reduction strategies, the United States healthcare system decreases the opportunities to obtain and receive affordable, accessible, and wide range of healthcare plans. The United States underfunds addiction treatment, and so this poses a significant barrier to those trying to find treatment. And again, people who are seeking care are often misconstrued and stigmatized and discriminated against in healthcare settings. In 2019, less than 1/3 of the 1.7 million people who reported having an opioid use disorder didn't receive treatment. And even though some of the most common treatments are methadone and norepinephrine, which, like I said, were anti-addiction medications and are highly effective, 40% of U.S. counties don't even contain any norepinephrine providers, and 24% of the counties have a low capacity to treat these patients. And in 2020, only 11% of Americans with opioid use disorder reported receiving any of these treatments. Meanwhile, in other countries, 50% or more are receiving these treatments. Looking at other countries, we see how they've embraced strategies to maximize safety. They provide clean needle exchange programs, supervise drug consumption sites, national programs that distribute naloxone, which is an opioid overdose reversal drug, which saves lives, and drug checking services that provide people with information on what their drugs may contain if they have been laced with other drugs. Germany has also a more regulated prescription control and more accessible treatment and harm reduction solutions that reduce the morbid fatality rate from overdoses. This is because their healthcare system is state-funded, making it more affordable, more accessible, and less stigmatized. 24 supervised drug consumption centers and clean needle exchanges are provided through 6 of their states, and they provide opioid substitution therapy through the anti-medications. Looking at Japan's national insurance system, they follow a similar approach by failing to provide coverage for non-chronic cancer pain, and this explains why the country has a low usage and prescription rate of opioids. Other countries in Western Europe and Australia have adopted methadone as their primary maintenance treatment for opioids to counteract not only opioid use mortality, but HIV mortality rates. And lastly, countries such as India and Northern Thailand have begun implementing buprenorphine maintenance programs as their primary modalities of treatment. So as we can see, many other countries are using more tactical strategies to combat the opioid use and addiction, countries that the United States doesn't. And that's
so wonderful to get to see that, especially after our conversation, I think 2 years ago, where you said, I gave her a little into this, and to see how much research has gone into it between now and then is really exciting. I'm going to invite your advisor up to present you with the cord and stole that you'll wear to recognize your accomplishments and honors, and we'll have a few minutes for you to take questions after that. Thank you.
Working with you has been great. Always so welcome to receive feedback and respond quickly to that feedback, and just a wonderful person to work with in general. And this really was like she did the work and did a fantastic job and investigated all of these different factors. It was potentially an overwhelming amount of information, and she did it very, very successfully. So great job. Thank you.
Questions for Mia? You're okay.
Do you have any perspective on what's the special thing about cancer-related pain as opposed to other forms of pain that countries would allow that but not treatment for non-cancer?
Yeah, so like, I guess I think it was just before OxyContin was released, like opioids were only prescribed for people with cancer-related pain just because, I guess, so severe. But after OxyContin, like, Purdue Pharma had a lot of corruption and a lot of like ins in the system, and like I said, they kind of just endorsed it and were already marketing it to medical providers and healthcare systems, like saying that, oh, like this can treat this little amount of pain, and like not really explaining how addictive the OxyContin would be. And so that's why I think it was endorsed to non-cancer related pain.
What are your next steps? Do you want to work in the pharmaceutical industry, make sure this doesn't happen again, or do you want to work in policy?
I don't know. So I actually want to go to law school, and so I've thought about I don't know what type of law I want to practice yet, but I've definitely gained an interest in like policy and like legislation, so maybe this could help and like spark an interest in that, but I'm not really sure.
Great job.
Thank you.
on the legal question, I thought it was so interesting that the German law came out even before Purdue had released OxyContin, and that, so not even necessarily in response to that, and it made me wonder, yes, it seems clear maybe what the US could have done then, we could have had a similar law, but in terms of policy, like what do you think we can do now?
Honestly, I think like the whole thing had to do with like corruption and like drug policy, and I think a lot of it was the influence of the Sackler family and like Purdue Pharma. So I think it's up to legislation and like what they decide. I know like laws have been enacted and like now they're trying to fund more for addiction treatment and like the opioid crisis, but that wasn't I didn't really look into it that much. So that's definitely something I could. I don't know. That's definitely something I could look into further.
It's your project for the future.
Yes.